All right, so this is going to be a in-depth look at obstructive sleep apnea. I know we've talked about OSA plenty of times, but this summer we're really going to get pretty in-depth with it in terms of the disease itself, the treatment options, all of that, because this really is our bread and butter in the sleep world. So let's start with the definition of an apnea. It's just the cessation or the stopping of airflow for at least 10 seconds while asleep. And that drop in airflow doesn't have to be completely dropped for the entire event. It's just at least 90% of the event, you have more than a 90% drop in airflow. So you might still see just a tiny little breath, but the gist of it is there is that if you don't have airflow for at least 10 seconds and, a significant reduction in airflow is really what it is. You guys know we determine the severity of it based on how many times it occurs each hour. So looking at our AI, our apnea index, our AHI, our RDI, that's where we really look at the severity. So there's three different types of apnea. The big takeaway from this picture is if you look at, and we covered up the effort here, and just looked at the apnea itself in our airflow channel, the apnea looks the same. An apnea is an apnea. And so when we say apnea, it really ultimately means the cessation of airflow for at least 10 seconds. And to determine the type of apnea, you really have to look at the respiratory effort and what's happening there. So obstructive is you have continued effort, there's a continued drive to breathe, and oftentimes we do see the effort might be a little dampened in the beginning, and then as the hypoxemia increases and the CO2 rises as well, the effort to breathe raises as well. The person's really struggling to breathe, and it increases till they ultimately wake themselves up and the airway opens back up. A central apnea is there's no drive to breathe, so you have a complete flat line here. So a central apnea is it's central in nature. There's something going on with the central nervous system. That's why it's called central apnea. That is preventing the drive to breathe. So there's not even an attempt to breathe here. The airway is usually in these cases wide open, and it's just that they don't have the attempt or the drive to breathe. Whereas obstructive, they have the drive to breathe, they don't have the ability. With central, they have the ability to breathe, they just don't have the drive. Mixed falls somewhere in the middle with there. So it always starts off as central and ends as an obstructive. So what happens with it is you have a little bit of a central where there's the lack in a drive to breathe, and then they get their effort back. But by that point, the airway is closed off, and so the apnea continues, but it switches over to being an obstructive. It's never the other way around. It's never obstructive first and then central. It's always central and then obstructive. Now, the problem with mixed is there really isn't a lot about it. So if you go back to your textbooks, you'll see there's a ginormous chapter on obstructive apnea. There's a good sized chapter, not quite as in depth, on central apnea. And then generally for mixed apnea, you'll find a paragraph, which is just the definition. So whenever I explain mixed apnea, I always explain it as try to lump it more in and think of it more as an obstructive event, in that it's more obstructive in nature. So if you think about the pathology of what happens when an apnea occurs, and the airway closes off, an apnea starts, the CO2 rises, oxygen levels drop, that causes the increased effort to breathe, and then once the person's able to breathe again, it's usually followed by a period of hyperventilation. So they're breathing really hard and heavy to blow off that CO2 that accumulated, bring the oxygen level back up. But what happens is sometimes people can hyperventilate, or the overshoot is too much. It's too great. So they hyperventilate too much and drop their CO2 levels below the apneic threshold. And so that's what accounts for this little central component. But then the CO2 levels rise back up, initiating the drive to breathe. But by the time their drive to breathe has returned, the airway's closed off, and that's where you get the obstructive component. So typically you might see mixed apneas oftentimes with pretty severe obstructive apneas, or somebody that has that's just prone to really overshoot and hyperventilate in between the apneic events. So an obstructive apnea is no airflow for at least 10 seconds with continued effort in the chest or abdomen or abdomen. Typically, we do see desaturations occur for an apnea, and they typically do end with an arousal in the EEG, but it's not part of the definition. It's not a necessary component of the definition. The main definition is that no airflow for at least 10 seconds with continued effort in the chest and the abdomen. Here's another example of what it looks like. And so what you can see is, again, no airflow, and it typically does end with an arousal right at the conclusion of the event. Again, not part of the definition. They don't always end with an arousal. Oftentimes you'll see that your RDI and your arousal index don't always match up, and that's completely normal because arousals aren't part of this definition. And what we can see in the chest and the abdomen belts is continued effort. And oftentimes you see the effort start to increase as the event goes on. And what you'll also typically see too is this paradoxical motion in the chest and the abdomen, where the belts, where they were once moving in sync with each other, they start to get out of sync with each other. So you've got to think that this person is struggling to breathe against an occluded airway. And what can often occur then is that fight to breathe causes that paradoxical motion to breathe, where the chest and the abdomen start kind of fluctuating out of sync with each other. The other thing that we see is there is a desaturation. Typically does occur with an apnea, but again, not part of the definition. Now remember, the oxygen, the SaO2 or the SpO2, is typically kind of time delayed. So it's not right in sync with the event itself. You have to miss a few breaths before you start to see the oxygen level drop. And at the same token, the person has to breathe a few breaths and kind of try to recoup the oxygen level that was lost before you see the oxygen come back up. Now, when you're scoring, one trick that was taught to me to be able to really, if you're having trouble, because sometimes, this is a textbook example. What you see in real life oftentimes is not textbook, but that the saturations, the desaturations, and the resaturations, they're concrete. It's numbers. You watch it go down, you watch it come back up. And so if you're having trouble kind of estimating the length of the event, if there's a few breaths that were kind of a little mid-line, you're not sure if it should be included as you're marking the start and stop of the event. A little trick, and it's not a rule, so don't take it as a rule, but a little trick is oftentimes the length of the desaturation is typically the same or similar length of the event itself. So that was a little trick that was taught to me as I was learning how to score way back in the day. And then the other thing that this example has is it has an esophageal pressure manometer in it. And so this is a device that isn't typically used for most studies. It's something that has to be inserted into the esophagus, and it's a balloon that then gets blown up. So it has to be placed by a physician. It's extremely uncomfortable for our patients. So it's typically not done outside of research situations, but it is the most sensitive detector of upper airway resistance. So even though in the real world, our gold standard for respiratory effort in the belts is your RIP belts, your inductance plethysmography, the gold standard for truly detecting and having the most sensitive and reliable signal of respiratory effort is the esophageal manometer. And so what you can see here is that upper airway resistance increases, and it kind of really does reflect what's happening in the belts as well, to really reflect that increasing effort that's happening as the event continues on. So here's a little flashcard, same slide, I believe, from your fundamentals lecture as well. I find that the little charts that I put together are really good if you're the type of person or studier that likes to make flashcards. These slides are perfect for that, to just review the different definitions of the different types of respiratory events and all that's required and all that you'll typically see. So obstructive sleep apnea, definition of the airflow will be the same whether we're talking about obstructive, central, or mixed. You have no airflow for at least 90% of the event with continued effort. Arousals are not necessary, but they do typically occur. desaturations typically occur as well, but are not necessary for the event to occur. The duration, though, is at least 10 seconds. So I don't know if you're the type you want a star. Like, this is the three main components of the definition: no airflow, continued effort, at least 10 seconds. This is what you'll typically see, the arousal and the desaturation, but it's not necessary and not a necessary component of the definition. So what happens with an apnea is the airflow gets blocked. And so it's a result of the upper airway muscles relaxing. Crazily enough, the only thing that really holds our airway open, it's a floppy tube, and the only thing that holds it open are muscles. And so when our muscles typically relax, which happens for everybody, our muscles relax when we fall asleep, that includes the muscles of the upper airway. And for some people, that relaxation can cause the collapsing of the throat, depending on the diameter of the throat, on how their anatomy is built, on the weight and size of their tongue as well. It's essentially just a blocked airflow that's happening in the upper airway. A hypopnea is pretty much along the same line as an apnea, in that the detrimental consequences of having hypopneas are the same as an apnea, and that's why we oftentimes will lump it together. We don't just look at the apnea index when determining and looking at the patient's severity and their whole clinical picture. We typically look at their AHI. Because the clinical and detrimental consequences of a hypopnea are right on par with the detrimental consequences of an apnea. So what happens with a hypopnea is the kind of the pathology behind it is the same. You have the upper airway relaxes and starts to collapse on itself, but with a hypopnea, the collapse isn't complete. You'll still get a little bit of airflow coming through, but it's just not enough to maintain a person's ventilation. So what happens with that is you do get the desaturation component, and that's a part of the definition. Is you have a drop in the airflow, about a 30% or more drop of the amplitude or the height of your airflow, combined with a 3% desat. Now, the rules for the hypopnea have been changing and updating, and they've changed a lot actually throughout the last, 5-10 years or so throughout in the sleep world. They've changed more than they ever have, because it used to be the required rule was that you had a 4% desat, and that was what pretty much everybody went by, and that was that. The 3% desat was the alternative rule, and not a lot of labs used it because insurance companies wouldn't adhere to that. They wanted to see the 4% as part of the definition. Well, then they switched to what was considered the recommended and the alternative rule, and now are recommending that most everybody go by the 3% DSAT, and the 4% is stricter, and it's the alternative rule. And so that was then one of the major changes that came about, and insurance companies, some of them were still slow to change. So what was confusing is when looking at a patient's history and looking at their report, you oftentimes had to look at their insurance to see what rule you were going by to define and configure their hypopneas. But now the rule has changed even more, where you have still the airflow is dropped, at least a 30% drop in the airflow or the effort, because remember, you look at both. And you have it has to be at least 10 seconds and a 3% DSAT. But where the new rule has changed things is that instead of a 3% DSAT, if there's an arousal with that 30% drop in airflow that lasts at least 10 seconds, that's an acceptable alternative as well. And that's actually the new recommended rule. So it could either be you have this component, and it could either be the 3% DSAT or an arousal. Some labs are using the arousal rule. A lot of them are a little, because this change just came about within the last few years. Some are slower to adopt it, and so some are still requiring that you still see a 3% desaturation, regardless of whether or not there's an arousal. You just have to verify the lab that you're at to determine which hypopnea rule that they are going by, because oftentimes it'll be dictated by the physician itself. So this is an example of what a hypop looks like. You have that diminished airflow, typically does end with an arousal that wakes them up, but not part of the definition. And you'll typically see what's happening in the airflow reflected in the effort. It might be a little bit diminished as well, increasing effort as the event goes on, ultimately causing the patient to wake up. But what you definitely will see is the DSAT. That's a part of most every definition of a hypopnea. And again, it's delayed. So it's not immediate. As soon as the breath is reduced, you see an immediate reduction in the SAT. You'll see it be a few seconds or a few breaths delayed. Same thing with the recovery of it. And in this one too, you have that esophageal pressure manometer channel to really show what's happening. And so I love these examples with the esophageal pressure manometer because they really show that as sensitive as our all the electrodes and sensors that we put on the patient, they aren't as sensitive as they could be, because what you're really seeing in the effort channel and this esophageal pressure channel is this crazy increase in upper airway resistance, ultimately leads right up to the arousal. You don't see this reflected in your effort belts. And so that's one of the reasons why that as we continue our journey and we start learning how to pick up events, respiratory events, that type of thing, you'll see I'm a lot more generous with scoring things on the side of being respiratory related versus saying, oh yeah, that's just a spontaneous arousal, just because, understanding what's probably happening underlying, if we had more sensitive sensors on, in all likelihood would be respiratory related. So that's where I try to, whenever possible, I do tend to score heavily on the respiratory side. I said this before, but apneas, hypopneas, they share similar mechanisms and adverse effects. So generally we consider them together when determining the disease severity, because their detrimental consequences that they have on the patient, on their health, on their sleep, are pretty much the same. You should know your mild, moderate, severe criteria of ratings by now. And this has also changed actually within the last few years as well. So if you see another lab using a slightly different scale, that's why they're still going off of the old scale, where mild was considered between 5 to 19, moderate between 20 to 39, and severe was anything greater than 40. Well, they've changed these a bit as well. So that's where you'll see, if you do see it reflected an old way, and where severe is considered greater than 40, they're just going off of the old scale. That's all. So when we talk about the clinical severity of OSA, it's not just about how many events that they're having. It's about looking at the greater picture of what's happening with the patient. And that's what we've been talking about pretty much all along. We started, your very first lecture was talking about evaluating the patient's medical chart, evaluating their questionnaires, evaluating, kind of looking at their overall clinical picture. Well, that comes in and has a huge impact on the overall clinical severity of a patient's obstructive sleep apnea, of their disease. So how much it's impairing their daytime functioning, how tired they're feeling throughout the day. Generally, we see that the complaint of daytime sleepiness correlates more with how fragmented or their sleep is, so their arousal index versus their AHI, but it all comes together. And everybody has their own levels of what they're able to tolerate. So there's also individual disparities in this as well. That's why we look at kind of the subjective complaints of the patient, how low their oxygen is dropping. So they might have an AHI in the mild or moderate range, but if their oxygen is dropping severely and it's staying hypoxemic, or there's just not a lot of recovery in between events, that really kind of bodes to looking at a more severe clinical picture. We want to see how much they're waking themselves up, so the extent of the sleep fragmentation. Does their disorder cause or exacerbate nocturnal arrhythmias? Or do they have an underlying disorder, especially like a comorbid heart disorder, heart disease, or congestive heart failure, that this having OSA on top of can significantly worsen and exacerbate that disease? So it all comes together to look at, how severe is it? Because it's not so cut and dry of your number is this is what you have. You really have to take every person into account, because we're all different, and you've really got to look at that whole clinical picture to get a better idea of the severity of the case that we're looking at. So the diagnosis of OSA, it has to be diagnosed. We can't go by evaluations alone. You can't just give the patient a stop bang, hey, you scored high on that, we're just going to skip the process of the sleep study and boom, boom, done, you've got the diagnosis. It actually has to be established. Just like any other type of disease, there are validated tests to define and better visualize the diagnosis of OSA. So it has to be a part of a sleep study. We can either do it in lab, an in-lab polysomnography, or a home sleep test. It has to be, we have to have a comprehensive evaluation. So look at the big clinical picture for the patient. And typically you'll find that, doctors are getting better and better now, like your primary care docs and heart docs and all of that, to start screening for signs and symptoms of OSA. Whereas before, even 10 years ago, not a lot of the doctors necessarily knew what OSA was or knew what questions to ask to determine whether or not the patient should get a sleep study. Now the word is out there, and so they are asking the questions. So just as part of a routine health evaluation, if a patient comes in, the doctors are starting to be able to better identify, like, hey, that looks like your symptoms that you're coming to me are suggestive that you might have obstructive sleep apnea. And also just looking at our high risk patients, so the ones that are much more at risk, are hypertensive patients, older patients, males, overweight, that type of thing. So questions that we should be asking, as part of the routine health maintenance, and you don't necessarily have to ask, is the patient obese? You can see that just from their height and weight, but just taking a look at their jaw, are they retrognathic? So that's that recessed jaw, or, if you were to look at it from a cosmetic standpoint, it's somebody with a weaker chin. And so you see that, and you can already determine, typically these are the patients that aren't obese, but they're the patients that are much more anatomically predisposed to having OSA because their airway is probably pretty narrow. What are the patient's complaints? Are they tired? Do they snore? And do they have a comorbid history of hypertension? Because that's going to be the recurring theme. OSA and hypertension just go hand in hand. So in order to diagnose OSA, it has to be done by an acceptable method, so either in-lab sleep study or home sleep testing, and then with that, determine the severity of the disease in order to make an appropriate treatment decision. So we've talked about PAP before, and we're going to continue that discussion as the summer goes on, but there are other treatment options. It's just they are limited by the severity of the disease, the patient's history. And so that's where it is important to put a number on their overall diagnosis, because that will help guide the treatment decisions. You got to take a look at, obviously, the overall clinical picture, but in terms of treatment options, RDI, AHI do play a major role in what treatment options are recommended for each patient. So just talking about the etiology or the cause of OSA, we're going to jump back and do a quick review of the anatomy of the upper airway. So if just basically this entire upper airway going from hard palate, soft palate, all the way down, it's just very collapsible. It's a floppy tube. And what happens is there's a lot of forces that maintain our upper airway patency, or our upper airway remaining open. That includes our muscles, sometimes the anatomy. But what happens in an apnea is those things that help keep and hold our airway open, they're just insufficient to combat or counteract the things that are causing the airway to close up during sleep. So causing that collapse on itself, that muscle relaxation, the kind of the floppiness of the tube. And so we typically do see a lowered muscle tone during sleep, and sometimes that lowered muscle tone is just too much in order to maintain an airway in some people during sleep. So they've done a lot of studies. Obviously, OSA has been studied heavily, and I know so far we've been keeping it pretty general. The main two things that cause OSA are anatomy and weight. But they're finding that anatomy, in all likelihood, probably plays a much larger role for most people than weight. And I don't say this to the patients. I do try to keep it positive I'm always trying to be careful about, this is a lifelong disease. Like, I don't want to be the one saying that and scaring them like that. But what they've found is that in patients with OSA, the airway does tend to be a little bit more narrower, but it also tends to be more vulnerable to collapse. And so there might just be something where some people's airway just tends to be a little more patent, and some people it just tends to be a little bit more floppier. And it could be because of their anatomy, because of their anatomical structures, because of, maybe their retrognathic, so their chin is a little bit recessed, maybe they have a larger tongue. But the other component of it is weight. When we gain weight, we gain it in all places, including the places you don't see. So you can have fatty deposit accumulation in the soft tissues of the upper airway. And in certain patients, when there's swelling, so mucosal swelling, so if you have somebody that's sick or that's a smoker, smoking is an irritant, it can cause swelling of the mucosa, and that will narrow the airway as well. And also just something maybe potentially of a muscle hypertrophy, or a muscle getting a little bit weaker. And so that would make it more prone to collapse, more floppy in and of itself. So what happens with OSA is you have these periods and these episodes of generally pretty loud snoring, and then all of a sudden it's silent. And it's those silent periods where there's no airflow happening. And those are the silence that you got to be worried about. And those are that's the silence that scares the spouses, because it means that they're not breathing. There's no airway going through their airway at all. Typically what we'll see is the heart rate can start to drop during the event itself. So when you stop breathing, the heart might also start to drop as well. So you get a little bit of bradycardia during the actual event. And then at the termination of the event, when the person's waking themselves up, you'll get that autonomic activation that can cause transient tachycardia. So you might see this constant fluctuation in the heart as well while the apneas are happening throughout the night. Bradycardia during the event, so when you stop breathing, the heart rate will start to slow, and then transient tachycardia at the end of the event. So when the person's waking themselves up, that arousal typically can cause the heart to jump up as well. What you'll see in the blood oxygenation is it's time delayed. So shortly after the start of the respiratory event, you'll see the blood oxygenation start to drop, and you'll typically see it reaches its lowest point, or its nadir, about 6 to 8 seconds after the termination of the event. So after the event has ended, that oxygen is going to keep going down, 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 and then it's at 6 to 8 seconds, and then you'll see it start to come back up again once the breathing resumes. So just think back of those pictures in the beginning of the slide. The oxygenation is time delayed, and so you'll usually see about that 6 to 8 second lag, and that might be slightly different depending on the length of the event, the severity of the oxygenation, that type of thing. There are things that can impact the severity of the desaturation, so what the patient's baseline oxygenation is going into the study when they're awake, when they're asleep. Generally, a lower baseline oxygenation will lead to more severe desaturations throughout the night. How much time the patient is actually having these events. So with, the definition of a respiratory of an apnea or hypopnea is it has to be at least 10 seconds. But if those events are more prolonged, you can have hypopneas last upwards of 60 seconds or more. So these very prolonged respiratory events are going to cause a very prolonged and more severe desaturation. Same thing with apneas. They can be quite prolonged as well. So the longer the event, typically the more severe desaturations that you see. The increased percentage, that would be the increased duration. So the increased percentage of sleep time is, what their overall AHI is. So, how much of the time that they're asleep are they actually having the event, or are they more centered or kind of limited to supine sleep or REM sleep versus having something that's pretty progressive throughout their entire sleep. And how much they're sleeping or they're breathing in between the events. So how much ventilation is happening in between each of the respiratory events. What I mean by that is some people will have these events back to back. So as soon as they wake up, they start breathing again, but then as soon as that sleep onset occurs, an apnea might start occurring again. And so sometimes what you see with the oxygenation is there isn't a full recovery in between events. It's that there's that time lag, and if they're only getting a few breaths in before the next apnea occurs, their oxygenation doesn't even have a chance to fully recover and come back up to normal before it starts dropping again. So depending on how much ventilation is happening in between the apneas can impact the severity of the desaturations as well. Other things is just what's the patient's lung functions, what's their underlying lung values, so their FRC, their residual capacity, and their reserve volume. What other types of lung disorders might they have going on that can impact their oxygenation? How much REM are they getting? Are they taking a medication that limits their REM? Then we might not see those, because we do typically see more severe desaturations during REM. But if somebody has less REM, you might not see those more severe desaturations during REM. Or are they have something that causes them to have more REM? Then you might see more severe desaturations. The type of event they found can also play a role in how severe we typically will see the desaturation. So more often than not, desaturations tend to be more severe with obstructive apneas than with central. So pathophysiology, what we want to look at is what's actually happening during the event itself. And so what happens is a person tries to breathe against an occluded airway, and that can change your intrathoracic pressures. So which can play a major role in blood pressure, cardiac output. And so when you struggle to breathe against an occluded airway, by lowering the intrathoracic pressure, it can drop blood pressure, it can drop cardiac output. But then as the apnea progresses, it can cause the blood pressure to rise. And so the other component of it is the sympathetic activation that's happening during all of this. So you've got this dampening happening while there's no breathing going on. So you got to figure when the airway is blocked, heart rate can drop, blood pressure can drop, cardiac output can drop, oxygenation is dropping, all of that, all these parameters are dropping. And then at the end of the event, you have this resumption of breathing and this autonomic activation with an arousal, and you see all these numbers jump back up again. You have blood pressure rising, you have the heart rate jumping up, you have all these numbers jumping up, and it's this constant and continual fluctuation of these parameters happening throughout the course of the night. And so when a person's parasympathetic division should be taking over and their body getting that rest that it needs, the heart getting the rest that it needs, it doesn't get that because it's constantly under this state of fight or flight, because this person is essentially getting choked out repeatedly throughout the night. And so it's this constant stress that it's putting on the heart. Really, the heart a lot of times is the main thing affected by OSA. So we talked about before the paradoxical motion of breathing. So you'll see that out of phase where the rib cage and the abdomen start to kind of like go in opposition to each other, to struggle to breathe, and that can cause a downward displacement of the diaphragm. And so when that happens simultaneously with the upper airway also being occluded, you have further changes in the intrapleural pressures in your rib cage. And then you have these positive pressures pushing against the abdominal wall. So you have all these pressure changes happening internally as well to further exacerbate the detrimental consequences and put stress and strain on the heart and all these other bodily parameters. Typically, we'll see the apneic episode end with an arousal. The patient just wakes themselves up, and it could be like a very gross body movement. Sometimes you'll see these patients, they flip and flop all over the bed, just, like struggling to wake themselves up to breathe. You might have really loud grunting or gasping or choking, really big leg kicks, things like that. These patients tend to be very active sleepers. And that arousal is what allows the airway to open back up. The muscles return to awake tension, and so the airway is able to open back up where the patient's able to breathe normally again, and hopefully the saturation level returns back to baseline. But then once the person falls back asleep, the cycle repeats itself. So here's a really good graphic of the whole cycle of what happens during an apnea. So we fall asleep, and what happens is we lose that muscle tension and tone, that hypotonia that typically occurs during sleep can cause the airway to collapse, which results in an apnea, but then your oxygen levels drop, your CO2 levels rise, and that increase in CO2 level further increases the ventilatory effort. So you have a person that really struggles trying to breathe because they have everything screaming in their body. You need to breathe. The CO2 level is just like a loud, obnoxious neighbor banging on the door, like, breathe, damn it, which ultimately results in the person waking up from sleep. And when we're awake, typically that pharyngeal muscle is restored, so the airway is able to open, and you'll see the person hyperventilate. They really try to blow off that excess CO2 and bring up their oxygen levels back up. They are awake, and then they fall asleep, and it all can happen all over again. So it's this nasty cycle that can continue to get worse and worse and worse as the night progresses. And it's really, you'll see this, and it's really sad. It always breaks my heart when I see patients, they don't ever really get a bit of rest. And as soon as they're asleep, they're just struggling to breathe and to stay alive. And it's, just this vicious cycle. And my heart goes out to them, and how tired and how probably poor they probably feel when they're walking into the sleep lab. But what brings me hope is how easily we can help them and correct all of that. So we do typically see the events tend to be longer during REM sleep. They tend to be longer in duration, and typically more significant falls in the oxygenation. In some patients, you can see it primarily or exclusively during REM. So that would be, REM related OSA. So there's not a ton of guidelines in terms of what to do for these patients if their overall AHI is normal, but they just have pretty severe or significant apnea during REM. Some clinicians will treat it, especially if the patient's tired, because again, you got to look at the overall clinical picture. Their overall AHI might be normal, but if they're complaining of being really tired and they have this REM-related OSA, that's one of the really great things about AutoPAP, because it can treat them when they need it, back off when they don't. And it's, like I said, every person is individual, so we have to really treat each person on a case-by-case basis. What you typically will see. This should be more of a review. What we typically see when a patient has obstructive sleep apnea on their overnight sleep study, we typically see they wake up a lot more than normal. They have a lot more of the lighter stages of sleep and a lot less of the deeper stages of sleep. So they typically have decreased stage 3, decreased REM, and sometimes in really sad cases, these stages can even be absent. So just imagine how tired that person must be when you're face to face with them in the sleep lab. AHI can vary night to night. It's not going to be the same every single night. And typical causes for why an apnea might be worse on some nights than others could be, how much REM the person got on that night, depending on either, their level of sleep deprivation or, a bunch of different factors can impact REM slightly. It's not going to be exactly the same every single night. What position the patient slept in, certain positions, apnea does tend to be worsened. So if the patient was able to get themselves into a position where their airway stayed open more, that can help reduce their AHI on that night, depending on how congested they are, so the level of nasal resistance. Alcohol, welcome to college. I'm sure you guys all know the effect of alcohol can have on your sleep and on your snoring and all of that. So, if you imbibe a little bit too much, people that might not snore on nights that they do drink. Obviously, use of medications, relaxant sedatives, opioids, and changes in their weight. We have water weight. Our weight can change on a daily basis. So as weight changes, fluctuates up or down, that can have a slight change in the person's overall AHI. Now, the variability of AHI, I think I've been asked this one before, it's not worth doing a multiple night study on a patient. So it's not like we're going to be like, okay, well, tonight you had your AHI was 20. Let's see where you're at tomorrow night and then the next night, and take your 3-night average to really get a gauge how severe your apnea is. That's just not cost effective, and it's not time effective for a patient. Could you imagine having, it's one thing to even, for some of these patients, it's just so foreign coming into some place and sleeping somewhere that's not home with a bunch of stuff on that's completely foreign to you, but then to be asked to do it over several nights to get the overall average. Because for the most part, we get a pretty good picture of what happens on the night of a sleep test. If they have apnea, they're going to have it. Whether their AHI is 20 on one night, 24 on the next, is it really going to change how we treat them? No, we're still going to recommend treatment. So, again, we can have a slight variability of our AHI, but not enough where it's worth doing numerous studies on a patient numerous nights in a row. It's a different thing to do checks on the patient if they've had a significant change in their weight, or if several years have passed since they've last been tested. Yes, that would be worth it. But I've been asked this before, like, well, if the AHI varies, how come it's not standard practice to do several nights per patient to get a gauge on what their OSA is? And the answer is it's just not worth it. So there's certain things that can make us more at risk for OSA. So genetics, if it tends to run in families, that really points towards a more anatomical predisposition for OSA. Gender is huge as well. It affects 24% of males versus 9% of females in the same age category. But that number does start to kind of even out once a female reaches menopause, and that gender disparity or that gender gap significantly lessens. And then the other thing we'll talk about in the fall semester when we start talking diseases is there are certain disorders that a female can have that significantly increases their risk for OSA as well. However, when we talk about what the AHI is and symptoms, I don't know if it's just us women, we like to complain more, but when we add symptoms into the mix, that gender disparity also starts to dissipate, whereas, men might not be complaining as much about their symptoms as a female might. Age, as we get older, everything gets floppier. I know I've probably said that before. So it includes the muscles of your upper airway. So age is a huge precipitator for OSA, and it especially, again, there's that gender gap starts to dissipate is in women once they go through menopause. It's most prevalent between the ages of 50 and 70, and then once you get to really old age, you start getting to a population that I don't want to say that it's not as prevalent in older people, that are 70, 80 years older. It's just, I think their willingness to come in and get tested starts to dissipate. There's a lot to be said about dying in your sleep. And I know that sounds morbid, but when you get to that age, that's kind of something that I hear fairly often from patients in that age, where they were very hesitant to get treatment because, that's kind of the way to go out for when you go out, unfortunately. Race can play a role in it too. They have found that there is a higher prevalence among African Americans, Mexican Americans, and Pacific Islanders. Not really exactly sure why. Anatomy is huge. So the neck circumference can give us an idea of what the patient's anatomy is. Looking at certain nasal features, so just looking at their nose itself, do they have a pretty narrow nose? Looking inside their nose, that's what the physician does. Looking for deviated septum, polyps, which are growths that can impact and block the nasal passages. Is the patient chronically congested? So, allergies, asthma, things like that, where they have that always kind of working against them, clogging up their airways. Do they have enlarged tonsils, adenoids? Do they have certain hereditary syndromes? So patients with Down syndrome or achondroplasia, that's dwarfism, they tend to be more at risk, those patient populations more at risk for OSA, just because of the typical anomalies, the physical anomalies that happen with those disorders. Nasal congestion, rhinitis can definitely worsen snoring in OSA. Just think about how well you sleep when you have a cold compared to how well you sleep when you don't. I mean, whenever I have a cold, nothing makes me appreciate breathing through my nose more than not being able to breathe through my nose. Excess body weight. So this is a huge one. Um, you know, we talk about weight all the time when it comes to a risk factor for OSA, but let's look at why. So where the weight is carried is important, because having the weight carried more centrally, meaning more on the stomach and the chest and the hips, and the neck, kind of correlates more to having a worse AHI and more severe OSA than just being more obese in generally, than having somebody that carries their obesity pretty evenly throughout. The other component of it, and this comes to the gender disparity, is where we carry our weight. That comes right back here. The gender disparity plays a role as well, because when men gain weight, they tend to carry their weight more trunkily. Women tend to carry it more on the hips and the butt. And so carrying weight more trunkily can weigh down in the airways, weigh down on the muscles to breathe, weigh down on the diaphragm, and worsen and exacerbate OSA. So that's another component of the gender disparity and why males are more at risk than females. So there's a couple different ways that weight can impact OSA. Not only can weight have a strong component in that it can weigh down on our lung volumes, being obese can impact the ability to take a deep breath, can impact the ability to, the muscles of breathing, and just, make it more crowded with the diaphragm, so it can decrease your airway size, but also where the fatty deposits are occurring. So we gain weight, we tend to gain it everywhere, and that can include in the upper airways, getting fatty deposits in the soft tissues of the upper airways, which can further narrow the airway, make it a reduced airway size, and can really put a more strain on the muscles keeping your airway open. So it can really impact the muscle tone of the upper airway in that regard as well. Smoking plays a role because it's an irritant. It can cause edema in the upper airways. It can also tends to cause people to have a lot of irritation in their airways and can become more congested, because congestion is the body's way of trying to fight and protect itself. So that can exacerbate OSA. I never try to really talk to my patients about if they are a smoker and talk to them about, oh, smoking can help this and that, because believe me, they've heard it. They've heard it from every single practitioner they've ever been to. I don't want to start our relationship off on that foot. I'm trying to create a positive experience for them in the sleep lab. So let the doctor have those hard conversations, and it's not my place to judge or anything like that. So I tend to not really talk to patients about their smoking, just because you'll get the yes of death, like, yeah. And I hate how I don't like starting our relationship, our patient healthcare practitioner relationship on that foot. Medications can significantly impact OSA, things that'll relax the upper airway more. So relaxants, hypnotics, narcotics, anesthetics, they all can bring on obstructive sleep apnea by really dampening the muscle tone of your upper airways. One of the reasons why whenever a patient is typically under anesthesia, they're put on an artificial airway is put in, because not only does the anesthetics knock out their drive to breathe, but it also just closes up their airway because the muscle tone just is not there. Alcohol. Alcohol impacts our sleep in a few different ways. Not talking about the changes on the sleep architecture alone, how it impacts our sleep in terms of risk for OSA is, alcohol will further relax the upper airway muscles and make it more prone to collapse. So alcohol and, the same kind of line of thinking for the sedative hypnotics and those types of medications, but they can impact and worsen the severity of OSA kind of like a trifold. So not only do they inhibit the upper airway muscles. They make them more prone to collapse because there's just, really just knocking everything out there. And then they also can make it so that the patient is less likely to wake up. They diminish that arousal response, meaning where without alcohol or taking certain medications, an apnea might last this long, and typically the patient's body naturally would kick in and wake them up. Well, when you're three sheets to the wind or you're really out of it on medications or whatever, it's going to make it that much more harder to wake a person up. And same thing with an apnea, which means the apnea can go on for a lot longer and, worsen the cognitive effects, worsen the desaturations of it before the patient will actually, their body will actually wake up and start breathing again. So it's kind of like a 1-2 punch that alcohol can have on OSA. And that's one of the reasons why in every single chart, that last paragraph that you read is kind of this like generic blurb that they put in about patient was counseled on the use of sedative, hypnotics, alcohol, da da da. And it's kind of their cover your ass kind of moment that they do that and where they add it in. But it's so true. And so that's their cover their ass that they, hey, we talked about how alcohol can make it worse, but they don't really talk about why alcohol makes it worse. They just say alcohol can make it worse, but understanding just how much worse it can make it might help the patients understand what risk they're doing. They're putting themselves in by drinking alcohol and having their apnea go untreated. So we know our high-risk patients that are high risk, they should be evaluated for obstructive sleep apnea symptoms. We should start looking at, could they potentially have this disorder? Overweight, do they have any heart issues, CHF, AFib, hypertension, and specifically treatment refractory hypertension, meaning that they're on medications and the medications just aren't doing enough to control their hypertension, because OSA can make hypertension just continue to spiral out of control. It's just this, if you remember from our hypertension talk in pharmacology, hypertension tends to be this nasty cycle in that the negative consequences that happen to the body because of hypertension can further exacerbate or worsen the hypertension. And so it continues to get worse and worse and worse and worse until the cycle is broken. But with obstructive sleep apnea, with all the medications in the world, in some patients, if their apnea is so bad that they're continually in that fight or flight mode, they're going to have such a hard time trying to control the hypertension. So in these patients, we always look at, could they potentially have an underlying OSA? Type 2 diabetes, they've found that OSA and insulin resistance can play a key role with each other, and insulin resistance is the cornerstone of what causes diabetes. So with diabetes, well, this is again, I know we talked about this in our A&P lecture, but I'm just going to jump back to it. But what happens with diabetes is the body just isn't able to utilize the sugar that's being circulated throughout the blood. So we eat something, our blood sugar rises. As a result, the pancreas releases insulin to be able to grab that sugar out of the blood and so the tissues can then use it in some way as energy. But with diabetes and with insulin resistance, you have sugar circulating in the blood, and our pancreas releases insulin, but the tissues are just resistant to letting that insulin in. And so the pancreas has to release even more insulin in order to eventually get the blood sugars low and for the tissues to utilize the sugars in the blood as energy. And so they've found there's a direct correlation with untreated apnea and worsening of insulin resistance, so worsening of the patient's disease course of type 2 diabetes. And treatment of one helps with the treatment of the other. So once they get their OSA under control, these patients, what they'll typically find, they might have an easier time controlling their diabetes as well. Maybe they might be able to back off on the injectable medications. Maybe they might be able to do a lot more controlling it through their diet and that type of thing. This kind of dysrhythmias comes back to underlying disorders of the heart, somebody that's stroke. So if we look at the detrimental consequences of all the things that happen with an OSA, we've got to look at the patients that are more at risk for for heart issues and stroke, brain, cerebral insults. So if they've already had a history of that, then we got to make sure that they're, covering our bases to try to reduce the risk of having a recurring issue. Hypertension, we already talked about that. High risk populations, truck drivers. So there's been a huge push for truck drivers, pilots, that type of thing, anybody that could potentially to do better screening. And it's something that's being taken over by the industry themselves. So it's not something necessarily coming from their doctors, but it might be the company they work for does these types of health screenings on their potential employees, to follow up and make sure that their employees are, if they're at risk for OSA, they've been tested, and if they've tested positive, they are reliant and compliant on treatment, because that puts the company at risk. Pre-op for bariatric surgery. So you'll see a lot of patients come through the sleep lab that are going through the process of trying to get approved for bariatric or weight loss surgery. Having a high weight puts anybody at risk, and so this population of patients, typically any bariatric doctor worth their salt will have the patient go through a process before they get approved, and part of that is having a sleep study, because the other component of it is not just are they more at risk because of their weight, but they're going to undergo an elective surgery. And so when you undergo an elective surgery, or any type of surgery really, but when you undergo a surgery, you're put under anesthetics, an artificial airway is put in, but then trying to come out of the anesthesia and get the artificial airway out, the recovery room has very strict standards that they have to maintain in order for the patient to kind of fully wake up and fully get discharged from surgery. And that includes certain oxygenation status, breathing status, ventilation status, all of that. But if the patient has an underlying OSA, it's going to incredibly complicate the post-op process, to the point that they found that the patients that have OSA, and coming out of surgery, are a lot more at risk for getting re-intubated, admitted to a hospital ICU, and just having a lot more health complications as a result. So what you'll see is that any patient typically going in for a surgery is told, or they're screened, do you have OSA? Are you on PAP? If you're on PAP, bring it with you to the surgery, because once they take the artificial airway out, they put the PAP on the patient, and that'll help them come out of the anesthesia, maintain their airway patency, and kind of do what they need to do to meet the post-op kind of requirements to be able to get discharged. And so they have a lot better health outcomes in that regard. So not only preoperative for bariatric surgery, that's part of the general screening, but a lot of docs now are doing just preoperative for any type of elective surgery. So if they can delay the surgery until the patient's able to get tested, they will. And so you'll see that a lot more too. And that's a good relationship. It really keeps, the business, the sleep lab kind of going, and it's this, bi-directional relationship to kind of help support other modalities of healthcare. So how we typically see OSA manifested, the patients might complain of sleepiness during the day, trouble kind of waking up. They might complain of snoring. Their bed partner might complain about their snoring, or seeing apneas, having repeated awakenings of gasping or choking, the nighttime sweating, nighttime diaphoresis. They're doing a lot of work. Their body is working hard to try to keep them breathed in throughout the night, so it tends to work up a sweat. The morning headaches can occur, and typically morning headaches are a manifestation from the fluctuation of the oxygen levels. That's something that you see more commonly in patients that have extreme fluctuations in their oxygen will complain of a morning headache. Bedwetting, unfortunately, is a side effect of it, because these patients just are so sleep deprived, and once they finally do get to sleep, they might not wake up to the signals of their body that they need to go to the bathroom. On the other side of that, though, what I love to see is patients that will typically wake up 2-3 times throughout the night to use the restroom once they're breathing well on a PAP. They make up maybe once, and what you realize is they didn't necessarily wake up because they had to go to the bathroom, but it was more of that, well, I'm awake, I might as well go to the bathroom. And so they're able to sleep much more consolidated. It's not just their breathing, but just the bathroom breaks as well. In terms of mood, you don't sleep well, it can impact all areas of your life. You can see increase in anger, a decrease in mood, decrease in your ability to handle stress. I mean, just think about when you're tired, our ability to resist stressors and to handle what's thrown at us on a day-to-day process, that ability to cope is just completely reduced. You might see the person's their sleepiness and the cognitive detriments are impacting their performance at work or at school. I've had plenty of patients that are on the brink of losing their job or have lost their job because they weren't able to stay awake during the day, and it's just so sad. Dry mouth on awakening. So oftentimes these patients do breathe through their mouth throughout the night, because the way I like to put it is, if you're getting choked, obviously you're going to try to open up your mouth to try to gasp in the air that you're not getting. And so oftentimes people do revert to breathing through their mouth during the night when they're having these apneas. Obviously I talked about too, they flip and flop throughout the night. They move a lot to try to just get to a position where they can breathe. Their memory, concentration. Some patients find that it impacts their marriage, their love life, diminished libido. And sometimes you'll see it come across that they feel like they have an underlying insomnia or an inability to sleep. So that's something to keep in the back of your head as well, is if you have somebody telling you that, oh, I don't sleep, that's my problem. It's not that I keep waking myself up, it's that I don't sleep at all. And to them it feels like an insomnia. It might not be, actually, because when you are sleeping and you stay in the lighter stages of sleep, specifically stage 1. And one thing, this will be fun when we do get into the lab again, I can have you guys do little nap studies, but electrographically we see that they're sleeping, but they just keep waking themselves up. But to the patient, it might feel like they haven't slept at all. Because it's that light of a sleep that to them it feels like they've just been awake the whole time. And so that's something you've got to keep in the back of your mind as well, is if they're complaining and saying, I just don't sleep, I have insomnia, well, it might be that they do sleep, they're trying to sleep, it's just that they're repeatedly waking themselves up because of their breathing. Other consequences that we can see is that obviously their sleep is impacted. They're waking themselves up. Their architecture is poor. They're staying in the lighter stages of sleep, not getting enough of the deeper stages of sleep. But we see these patients are more at risk for death, death in sleep. They are more at risk for heart attacks, stroke. It puts a huge strain on the heart to continually do this much work throughout the night. So coronary artery disease, congestive heart failure, and CHF and OSA have this bidirectional relationship, meaning that if the patient has an underlying CHF, as CHF gets worse, it tends to worsen OSA, just because congestive heart failure is a fluid accumulation, and that increase in fluid can exacerbate an underlying obstructive sleep apnea as well. Other consequences we see is arrhythmias. They're more at risk for stroke and other cerebrovascular diseases because of diminishment in the blood flow. Their heart rate's dropping. So that means that all the blood that should be pumping to all areas of the brain is not happening. And then combine that with hypertension. So again, if you want, we can do a little look back on the hypertension lecture in pharmacology of that nasty cycle that happens with hypertension, and the main organs that are affected are the blood, the kidneys, and the retina. Another consequence we might see is GERD, or gastric reflux. And that's a common occurrence because of specifically the changes in the internal pressures that we talked about that can happen while an apnea is occurring. And then that struggle to breathe, that paradoxical motion to breathe, can help and worsen acid moving up the airway even more. Other consequences we talked about: insulin resistance. There can be, diminished libido, obviously a negative impact on academic social performance. The people might start to withdraw from socially. They're always tired. You don't really feel like going out. You don't feel like you're not in a good mood. You don't feel like putting yourself out there. Increased risk of car accidents, and just any type of accidents at work, car, whatever. Marital difficulties. So it's kind of a fact of life that when we're having a troubling day, the person, even though it might not be their fault, but the people we tend to take it out on are the people closest to us. And so same thing with these patients, is they might feel and unfortunately take it out on the people that are closest to them, and that's their spouses and their families. Overall, if you're just not sleeping well, it can just cause it just diminished quality of life. You're not living your life to your fullest. You're not alert. You might feel more instances of anxiety, depression. You can see it change your personality, irritable. So there's a lot of different impacts that being tired can have on the personality, on just your overall well-being. And that's aside from your overall, just, the physical consequences of obstructive sleep apnea. The strain it's putting on the body, the strain that it's putting on, your heart, your brain, and all the other organs and stuff that are getting impacted by the fluctuations in the oxygenation. It really makes my heart go out to these patients. And I feel so strong. That's why I feel so strongly about treating everybody and giving them the best shot that we can, educating them appropriately to try to give them this change, because this is something that can be easily treated. And what I love about PAP is it's getting treated without a pill. It's just air. And so that's one of the reasons why I feel I'm a huge advocate in this field. So another issue is this hypertension. So let's take a closer look at the hypertension. So they've tried to correlate severity of OSA with how much it can impact blood pressure. And what they found that with each increase in the point of the AHI, it increases the odds of hypertension by about 1%. So by trying to correlate the severity of the AHI correlates with the severity of the hypertension risk. They've also found that oxygenation dips significantly impact hypertension risk, where a 10% drop in the oxygen levels, so say their oxygen drop from 95 to 85, increase the chances of having hypertension by 13%. So it's kind of twofold, interesting enough. We think it's just, the work of the heart, but it's not only how many times that the apneic events are happening per hour of sleep, but also the detrimental consequences it can have on oxygenation that is causing the increased risk of hypertension. So it's like, again, another 1-2 punch that's happening on the hypertension risk. So where we typically see blood pressure falls during nocturnal sleep, and that's what's known as nocturnal dipping. Nocturnal dipping is when our blood pressure drops, our heart rate and our respiratory rate and our tidal volume, it all naturally drops slightly from baseline when we fall asleep. What happens in patients with OSA is they don't have that nocturnal dip. They don't have that dip in their blood pressure. And instead, each time that an apnea ends and they have that autonomic activation, the blood pressure tends to increase slightly, and it keeps increasing. And so I know I've talked a lot about hypertension, but just I add this in to really hone in how much they are related. And they've thoroughly studied treating OSA and its result on hypertension. And it has significantly shown that it has resulted in, by having OSA under control, patients do return and normalize in terms of the nocturnal dipping. Their blood pressure does start to drop at night the way it should, and their body's ability to control the hypertension and the blood pressure improves as well. So it really, especially for these patient populations, to hone in those facts of just how related they are and how treatment of one can significantly help treatment of other, because we tend to forget everything's related. And so I always find that some patients end up at the sleep lab because they went to the doctor for something, but then that led to a bunch of extra tests on everything else. And it's almost like, I understand why some people avoid going to the doctor, because they want to avoid opening that Pandora's box of everything that they might need, that they might discover. And, ignorance is bliss, but by understanding how everything is related might help them be a little more open to therapy and open to helping themselves. So our overall goals of therapy is just get them sleeping better, help them with their symptoms, try to just improve their overall quality of life, and just prevent all of those long-term detrimental consequences that can happen when OSA is left untreated. All of the stress and strain it's putting on the heart and on the brain and on the body. Just let's try to stop that. Let's try to stop it in its tracks and give them an overall better quality of life and a longer life if possible. So the treatment, there's a bunch of different treatment options, and we're going to go through it all throughout this course, the summer course. We're going to talk about each and every one of these. You've obviously seen that we do try to, pretty much every patient is counseled to lose weight, but that's not really a treatment for OSA. It's more of an adjunctive therapy because it takes time and it's difficult, and there's poor outcomes with weight loss because it's hard. So we try to include that as, this can help, but here's what we're going to do to help you right now. So positional therapy, oxygenation therapy, there are certain medications, not a lot. We're going to talk about PAP, we're going to talk about the oral appliances, and we're going to talk about surgeries as well. Different lectures, not this one. But what we want to look for is when these patients have OSA, we want to look at, does their complaints of sleepiness improve? And that's where we can use those subjective measures like your Epworth sleepiness score. It's part of insurance, it's part of just the routine therapy. We have to get a score for each patient, and continue to check it. Has it improved throughout time? There are other questionnaires out there that are specific to OSA and measuring their quality of life, and you can do one. Some labs or DME companies used to do that as during the initial setup appointment when the patient was getting their PAP, and follow up in a couple months just to compare their scores. Talking to the patient and talking to their bed partner and their spouse and their family, do they notice a difference? We want them to notice a difference. We want them to all feel better and feel like this is helping them. Are they sticking with therapy? It's not going to work if they don't stick with it. Are they avoiding things that could potentially worsen their disease? Are they doing things to actively help themselves and improve their health outcomes? Or are they still engaging in all the habits that put them there in the first place? We want to make sure that they're giving sleep the precedence and the importance that it deserves, making sure that they are giving themselves the ability to get an adequate amount of sleep, and understanding how important it is to get an adequate amount of sleep. So employing and practicing proper sleep hygiene and doing things to try to help their other outcomes like weight loss if they are overweight or obese. We're going to switch gears slightly and talk about snoring and UARS, upper airway resistance syndrome, because that's part of the OSA spectrum. Whenever I describe OSA to patients, I like to describe it as more of a spectrum disorder. On the severe end of things, we have apnea, where the airway is completely closing off. On the mildest end of the spectrum would be snoring, which in and of itself can be just an annoying noise. It doesn't necessarily have to have any significant detrimental consequences, or it can wake the person up. It can cause you to wake up, and that can be problematic. Midline of the spectrum would be where the airway is closing slightly, but it's still causing the oxygenation to drop. And any and all of these event types all fall under the umbrella of OSA diagnosis. And so a patient can have the diagnosis of OSA without ever actually having an apnea. And that's why and how I've sort of formulated my explanation to the patients, because there's been plenty of instances that I explained what apnea is, and then I open up their chart to go through the PSG report, and I find that I end up, explaining OSA and then have to backtrack and be like, well, you didn't actually have any of that. You had more on the mild end, but you still have OSA. So that's where I kind of, I got caught in enough situations like that where I had to backpedal, that I kind of changed how I explain OSA to kind of just encompass the whole umbrella of what OSA entails, and that includes snoring and upper airway resistance. So, snoring is caused by a partial obstruction in the upper airway, which causes these noisy vibrations that can occur during inhalation and exhalation. Typically occurs mostly during inhalation. In some patients, it can occur during both, but it is the most frequently caused respiratory disturbance during sleep. People can snore and it doesn't cause an issue, but it's so frequent. It's the most frequent respiratory disturbance during sleep. So what happens is it produces this vibration of the upper airway structures, including your soft palate, the uvula, all the upper airway soft tissue, and it can cause the airway to kind of become more narrow during sleep. Typically, like I said, occurs during inhalation, but can occur during exhalation as well. So I do have a short video from YouTube that kind of explains what snoring is. So I'll play that now.
When you breathe, air travels through your nose, down the throat, through the windpipe, and into your lungs. The narrowest part of that pathway is in the back of your throat. When you're awake, muscles keep that pathway relatively wide open. But when you sleep, those muscles relax, allowing the opening to narrow. The air passing through this narrowed opening may cause the soft palate to vibrate. This causes snoring. In some people, the throat closes so much that enough air can't get through to the lungs. When this happens, the brain sends an alarm to open the airway. Most often this is associated with a brief arousal from sleep. The brain quickly reactivates the muscles that hold the throat open. Air gets through again, and the brain goes back to sleep. This disorder is called obstructive sleep apnea. Procedures to stiffen or shorten the soft palate can improve snoring. Procedures that open the airway in the back of the throat can improve sleep apnea.
So I find that videos like that help to better visualize. I like those little graphics to see what's happening while they're explaining it, and it helps me get it straight in my head what's happening to better be able to explain it to a patient, because that's the biggest component of it. Is it's one thing to understand it for yourself, but teaching it, you have to have an even greater understanding to be able to explain it to a person, to a patient, in a way that they're going to understand. So with snoring, it can occur in any age group. It affects kids as well. Up to 20% of kids snore. That's a lot. Men tend to be more affected than women, but it affects the majority of adults. Up to 60% of adults over 65 snore. And it's found that it is very prevalent in patients that have OSA. It doesn't mean just because somebody snores, it doesn't mean they automatically have OSA, but what they found is that patients that have OSA, snoring oftentimes can be a symptom of it, to kind of point towards that they might have an underlying upper airway resistance going on that could be severe enough to cause apneas. I love this estimation that it's present in about 25 to 95% of snorers. So they've really, made a wide gap there, so they can't be wrong. I hate when they do stuff like that, but primary or simple snoring is just that. It refers to just simply snoring. That's how I remember the name. Simple snoring, simply snoring. It means that it has nothing else, none of the other negative detrimental consequences that you might see with apnea. There's no apneas, there's no hypops, there's no impacts on the oxygenation or on the patient's arousals. They're not waking up, they're not having arrhythmias. It's only that. It's just the snoring, it's just the noise, and that's it. It has no negative consequences other than just a simple noise. The risk factors for snoring, sleep deprivation. So have you ever noticed that when you're really, really tired, I know plenty of people that say this, they don't snore except when they're really, really tired. And that's because sleep deprivation can impact our sleep architecture. We tend to go into the deeper stages of sleep. We tend to have REM rebound and stage 3 slow wave sleep rebound when we're really, really tired, and that can put a person more at risk to snore. Sleeping on your back, so that goes in with the whole gravity. Gravity's working against you. Overweight, having nasal obstructions, again, smoking, it's an irritant. Alcohol, muscle relaxants, all the things that the reasons why it puts a person more at risk for OSA. It can put them more at risk for snoring just because they can relax the muscles even more of the upper airway. They can diminish the muscle tone and the patency of the nasal passages even more to bring on snoring. So some consequences: patients might complain of dry or irritated throat when they wake up because of the snoring, because they're typically breathing through their mouth when they snore. When you look at somebody that complains of snoring, then you can look at some of the other risk factors. If it might be associated with OSA, it might be a symptom of their OSA. Generally, we don't do a sleep study on a patient just because they snore, unless if there's thoughts that it could be related to something more severe like OSA, or if they're thinking about having surgery for it, upper airway surgery. Generally, the docs like to get all their information and ducks in a row before they'll do surgery for something like that, just to get a baseline of what they are before, and then be able to see again what impact the surgery had on their upper airway. But we want to know, like, how long did it last? How often does it happen? What's the intensity of it? So, do you typically snore all night? Does it tend to be positional? Does it tend to more occur when you're really tired or certain things bring it on? How loud is it? Could somebody hear it from down the hallway, through a closed door, or does it tend to be light? That type of thing. So kind of getting a better grasp on the nature of their snoring can help with how severe it is. Generally, we don't treat just snoring, primary simple snoring, because that's all it is just noise. There's a lot of over-the-counter things that a patient can use to try to improve it. There just hasn't been enough legitimate medical research on these things, like your nasal dilator strips, those nasal strips you put over your nose. They also have these internal devices that are now that they like clip onto the septum of your nose, and then they like poke out your nares and make them bigger that way. They have lubricants that you can swab your nose with to try to improve snoring. I mean, you've seen it all. I'm sure you've seen the commercials, magazine ads, all of that try to claim like it can reduce your snoring. But there isn't a lot of data on these to really know if they do, how effective they are. And again, it's so a case by case basis. Upper airway resistance syndrome, or UARS. This was something that was a diagnosis that we gave to a lot of our patients, especially before the advent of RERAs. And so these were the patients that clearly had related repetitive issues with their breathing related to the upper airway resistance that impacted their inspiratory airflow. It kind of caused them to struggle to breathe a bit. It can oftentimes cause them to wake up because of the upper airway resistance. However, the upper airway resistance was not great enough to cause a significant impact in the patient's breathing to meet the definition of an apnea or hypopnea. And so these were the patients that oftentimes went untreated because insurance wouldn't cover the treatment for apnea if they didn't technically have apnea. And that's where RERAs came about, by creating and recognizing that they do truly have an upper airway resistance going on that's causing them to wake up from sleep. And we know the arousals from sleep have negative impacts on the hypertension and can have negative impacts on a lot of these other bodily parameters, much like OSA does. That's where the advent of RERAs came about, to be able to encompass it in the OSA diagnosis. Generally, what we found with these patients with UARS is their AHI was less than 5, and they didn't have significant consequences on their oxygenation. Typically, they would snore, sometimes not. But what it was found was that these patients, if you looked at their RDI, if we counted their RERAs, they did have an issue. They are waking up enough that it's causing them to have an impact on their sleep. And it's thought that these patients might have a lower arousal threshold, meaning that they wake up a lot easier in response to these respiratory increases in the respiratory effort compared to patients with OSA. And it could be that patients with OSA are just that much more sleep deprived, that their arousal threshold has raised where their just body is so tired. Who knows? There's still a lot that we don't know about all of this. UARS, though, has been found that it can affect people of all ages. There's not really a huge gender difference in it. Generally, people with UIRS are younger and leaner, but the treatment approaches would be similar to OSA. So CPAP, oral appliance, potentially upper airway surgery if there's an underlying anatomic predisposition to what's causing their breathing difficulties at night. But that's where we came up with ARERA, respiratory effort related arousal. And so that's part of the definition. It's an arousal that is associated with an increase in respiratory effort. So it doesn't meet the criteria for an apnea because you have continued airflow. It doesn't meet the criteria for a hypopnea because you don't have the 3% DSAT, but it is at least 10 seconds long, and it is counted as part of the RDI. So it is part of the overall kind of umbrella, it's within the umbrella of the OSA diagnosis. So this is something it would look like. With the airflow channel, you don't see much. What you can look for is signs and symptoms that you see ARERA in snoring. So whenever you see snoring, that's signs and symptoms and indications that upper air resistance is happening. You might see more deflection in your rip belts because the rip belts are pretty sensitive. And typically you'll really see the ARERA best demonstrated in your nasal pressure transducer because that's a very sensitive sensor that can pick up minute changes in breathing effort, and you can look at the shape of it. So as we continue scoring and getting used to and familiarizing looking at your signals and reading your signals, starting to learn the shape of things. So nasal pressure transducer, when you start to get like a squared off shape on it, that means that it's hitting upper airway resistance. But here's an example where you do have the esophageal pressure manometer. And so you don't see, if you were to look at your belts and your thermal sensor, you don't see a huge fluctuation that would indicate that there's underlying upper airway resistance, breathing issues going on. So without this, we might cause this arousal spontaneous. But with the esophageal pressure, what you can see is there's increasing upper airway resistance, ultimately leading up to the arousal. And so this is one of the reasons why I look for the most minute clues that tell me, could this potentially be OSA or like upper airway resistance related? So then that way I can kind of score it in that regard to better kind of give it to the patient to help them with establishing an OSA diagnosis so they can get the treatment versus calling this a spontaneous arousal. Here's again one of those little charts that kind of summarizes the definition of ARERA. I think these slides would probably be best for if you're putting together flashcards to help study the definition of the events. But typically what you'll see for the definition is the airflow. You'll typically see a slight reduction, but it's not at the level that you would see for apnea or hypopnea. You'll generally see gradually increasing respiratory effort, but an arousal must occur. That's part of the definition, and it has to be at least 10 seconds. So these two components, the arousal and the DSAT, or the arousal and the duration, are the two components that are part of the definition. And these are the parts that you typically will see. I should probably go back through and color code these or something so you'll see what's definitely required and what is typical. Typically you won't see a desaturation. You might see a 1 or 2% desaturation, but not enough to warrant calling it a hypopnea. But the arousal must occur. And that's the only respiratory event that we have, apneas, hypopneas, where the arousal is part of the definition. And the way to remember it is it's part of the name, respiratory effort related arousal, ARERA. So comment on this lecture if you have any questions. I know that was a long one, pretty in-depth look at OSA, but ask questions if you got them.